overall, if you see, most of the effects of calories, harmful effects, are either dealt with in most of the other systemic chapters, maybe liver toxicity or pancreatic toxicity or many other things. But so overall, you may not expect much questions from this chapter. However, what would be important from the exam point of view from this chapter is some of the regulations which are getting applied. We daily see, right? We see labels of the different food items which we buy from the market, maybe as simple as bread or biscuits to complex nutritional products. So there is a labeling part of it, and there are some regulations behind those labels, and behind those regulations is the science of toxicity and the science of and the biology of feeding and digestion. So this is really an interesting chapter as such, although it may not carry much weightage in terms of the questions which you could expect for a DABT. However, what I plan to do is, I know your exams are quite near. I don't want to waste much time of yours, but I would like to quickly go through, some of the basic things. This is not covering in totality with some, in terms of some other textbooks. I have taken Gastroenterology as a major textbook to have some summary points, which I feel would be more than enough for an exam. So let's get started, and we will start first of all with some basic biology, then what exactly are the toxic effects of the calories, and then how the FDA and many other agencies are trying to cope up with it, not only at the level of the patient, but also at the level of a state or a national level, what laws it is bringing up and how it is enforcing those laws. So let's get started with some basics. Now, you may all know that we all need energy, and this energy comes from the food we eat. And basically, this food is categorized into multiple nutrients. These are organic and inorganic. Mineral and water are inorganic, whereas carbohydrate, protein, fat, and vitamin are. We know that minerals, they would not constitute much of our body weights, and again they are divided into two, macro and micro. So how do we define them? If we need them more than 100 milligrams per day, or if they are forming more than 0.1% of our body weight, we call them macro minerals. And on the other way around, if they are lesser than 0.1% of our body weight, or if we require them in 1 ppm level, we call it as trace elements. However, quantity wise, they may be lesser required, but they do have very essential functions in our biology. So they are important as such. So this is overall about the nutrients. You may also know a lot more than me on the digestion, because you must have read, the toxic effects on the digestive system. And so you may be knowing more now that you are preparing for the exam. But then let us go through this, because this also helps us to relate to few of the terms in the regulations and the labels. So we know that the digestion starts right from the mouth, especially for the starches and the carbohydrates, and it goes right up to the level of small intestine, the duodenum, jejunum, also involved in this, or digestion of and absorption of all the nutrients. So mechanically, it starts with in the mouth, stomach, and the small intestines, where this is being broken down, and then there is a chemical breakdown as well, which is taken care by all the enzymes.
Sorry to interrupt. Audio is not at all clear, sir. Can you please check your mic?
Oh, sure. Thanks for that. Is this slightly better?
Bluetooth guys.
Yeah, looks better, sir. Please continue.
Okay, thanks. Okay,
Again,
so
some background noise is coming.
Is this better?
Yeah, good, sir. Let's continue.
Oh, okay, thanks. Okay, so we also have a list of amylases, lipases, proteases, and nucleases, which comes mainly from the pancreatic enzymes, which carry out about 50% of the digestion for carbohydrates and proteins, and almost up to 90% for fats. Major sites of absorption in the small intestine are jejunum and ileum, and they are modified uh, anatomically by increasing the number of folds, and also the villi or projections, which increase basically the surface area for absorption. And then different nutrients are absorbed by different processes, maybe the simple diffusion or a facilitated one, and the active one where we expend the ATP for the active transport. So these are the different nutrients wherein you may be knowing most of it, like how these are getting digested. So carbohydrates are broken down up to the monosaccharide, mainly the glucose and fructose. If it's milk, then also galactose. Proteins are digested to first of all polypeptides, and then to single amino acids, dipeptide and tripeptide. So these are basically the absorb units which are getting absorbed. So all this digestive system break down all these complex processes to as small as these molecules which get basically absorbed. And then fats, we know that it's get absorbed as fatty acids and glycerol, which are again reassembled in the liver cells and circulated throughout the body. A very important role is for the gut microbia. This and they not only help in slight digestion of the fiber, but main role of them is in the process of fermentation, where they give us B complexes. And you may all know, most of the time when we do take antibiotics, this flora gets affected and we feel weak because these B complexes are not, we are not getting them because of killing of these normal bacteria as well. So overall, these are all the nutrients which are getting, giving rise to us. I mean, they are helping us in providing the energy component. So this is just a summary of what are the different digestive activities. First of all, which takes place in the mouth, different organs which are involved. I'll not go through much of it. You know most of it. Then this is not important as well for the exam point of view. However, it is just mentioned here for the sake of having completeness of this notes. So you may be knowing like what are the different sources of different enzymes in the stomach. It's likewise also in the small intestines and the large intestines. So I will be sharing this PDF with you all. If you have time, you can go through them. It has some collections of other sources as well, where things are summarized and tabulated. So if it saves your time, it can help you. All right. So once we know that how this is getting digested, there is a good integration of different nutrients which are getting absorbed. So our body is a good system wherein it takes care of when we are having a good days, and also it has a good storage potential where when we are having a bad days. So remember, we have evolved ourselves from from the monkeys, and at those time there were days when we were having good food, and when we didn't had days where we had to undergo starvation. So our body is basically evolved, but some of the genetic functions have still remained back. So these do have a play in even today. And now let us understand how the metabolism of different nutrients, their storage, and how these are integrated. So we know that we are in a continuous need of energy, but we don't always keep eating. So there is a storage which is there in the body. For the carbohydrates, the major breakdown product is glucose, and the way it is stored is in the form of a glycogen, and this is stored mainly in the liver and the muscles. For the fat, the storage molecule is the triglycerides, and this is mainly stored in the adipose tissue. Whereas the proteins, as such, these are not stored for utilizing it for the energy level, but it is mainly for the structural components of our body. And it when proteins are broken down for the liberation of the energy, it is mainly the last nutrient to be utilized. Then we talk about the glycogen, how efficient is the breakdown of the glycogen. So what happens is when we are using glycogen, actually it is a hydrophilic molecule. So when we take its weight, it is 1 part of glycogen and 3 parts of water. So usually when sugars are broken down, they are based on some experiments, it is understood that they would give 4 kilocalories of energy per gram of compound. However, for glycogen, because 3 parts are coming from water itself, so it's actually 1 kilocalories per gram when they are getting metabolized in the body. So keep a note of this. Uh, if there is any question on why there is a reduced energy produced in the body when the glycogen is metabolized, it's basically because its weight is coming from the three molecule, the other 3 parts of water, which are associated to it. However, when fats are broken down, they give around 9.4 kilocalories per gram of the energy. We need to know that there are some preferences of different organs for the nutrients. So brain continuously need glucose. It doesn't have any internal stores. Uh, Whereas hearts, liver, and muscle, they prefer fatty acids for the oxidation and meeting their energy needs. And we know that proteins are mainly used for repair and body structures, but only when, in the case of prolonged fasting, when all other resources are used up, only then the proteins are broken down for energy. Of course, insulin is required to, whenever we eat, there is a secretion of insulin, and this helps to absorb not only glucose but also circulate it and get it. Different organs, they can uptake the glucose. It is because of the insulin. Not only that, it also promotes the uptake and storage of other nutrients like the proteins and fats. Whereas when there is fasting, hormones like glucagon and cortisol, they release the glucose from different organs by inducing lipolysis and gluconeogenesis in these organs. So this is how actually I may not go through all of them, but this is how things are integrated. So there is a continuous flow of energy which is maintained in the systemic circulation. And of course, these are the different pathways of how this is met. So talking more about the theory and the neural or the nervous control on the energy balance. So there are different theories which have been put up, of course, and then there are also understanding of how different chemicals at the level of different tissues are integrating amongst themselves, and how the nervous system is trying to seek a balance between the intake of the energy and the expenditure of the energy. So there is a normal energy homeostasis that is maintained. So one of the theories is set point theory, which suggests that our body has a preset level, and it will try to accommodate only that much amount of food through the appetite centers or other chemicals, wherein we are having a control on the food which we are eating. At the same time, it uses the inputs which are coming from different tissues, like say leptin from the adipose tissue, to sense how much is the food which is stored or which is even more further required. So it tried to basically balances the intake and the output of the energy. Then as we just spoke, these are leptin is one of the component which is released by the adipose tissue when we are having enough stores. It gives a feedback to our nervous system of having a controlled appetite. Similarly, our ingestive behavior is there are some behavioral controls by other systems in our body, which we will in our brains, which we will discuss shortly. So apart from the leptin feedback mechanism, which we just spoke, there are a few more neurons in our nervous system, and this are helping us to either balance out the requirement of more food by increasing the stimulating the appetite centers, mainly in the orexigenic neurons, and basically these are the different types of neurons which helps to stimulate and increase the feed intake. So these are basically the neuropeptide Y and the agouti related peptide. At the same time, we also have anorexigenic neurons which suppress the appetite. So if these areas of the brain are activated, mainly the POMC or the CART, we will feel our appetite is suppressed. And all these neurons are located in the arcuate nucleus of the hypothalamus. So these are one of the major nervous tissues which are involved in controlling our day-to-day appetite. In addition, there are also other neurons in the mesolimbic system, in the ventral striatum, and in the corticolimbic system. These are over and above. So let's say if you have read a particular chapter in from the Cassette and Doll, and you feel happy and you want to reward yourself maybe by having a bite of Cadbury or something. So although your energy levels are met and controlled by the upper nervous system, which we just mentioned, so these are additional rewarding or hedonic eating type of signals which can be released by your body, and these are something which is over and above the system which balances your energy intake and output. All right, so now we are talking now in this chapter about how what adverse effects would calories have. So basically, and if you want to treat it out, treat this disorder or treat this excess, you would like to make or understand what exactly would be a type of caloric intake a person is having, what is basically different expenses that patient is trying to make, maybe in the form of a biological activity or exercise, and then you want to make sure that to treat him there should be a proper energy balance, and his expenditure of calories should be more than the intake of calories, so that you are trying to expense his stored energy, so that there is a reduction in the calories, or to treat him. So if you want to really know, there are you would first want to know all these different inputs, so that you can maybe properly arrange a diet plan for him, or suggest exercise regimen. So to understand or to chalk out such programs, there are different ways in which the scientists are evaluating what should be the caloric, what basically should be the caloric intake, calculated and evaluated or measured. Then they would like to know a particular food which is being given, what are their caloric contents. So basically a diet chart can be planned. Then what are the energy expenditures a person is making. So for evaluating all these different steps, there are different methodologies which have been described in this chapter. So we can go through them very quickly. So this first session talks about the caloric intake. So how much or what is the amount of food, or in terms of also calories, is defined by, in animals it can be studied through through the metabolic cages. Most of the times we know in toxicity studies, metabolic cages are used to evaluate the urine output and for urine collection. And in addition to that, for caloric experiments, we can also offer food and measure the feed intake. And there are different ways in which we can evaluate the density of each and every ingredient of what that feed made up of. So basically this helps us to understand what are the different, what is the caloric intake by a particular group of animals. So Likewise, in the clinics, there are different methodologies. So let's say if your dietitian wants to understand what is your eating habit or eating pattern, it will ask, that he or she may ask you to record what is your pattern. So maybe there are different methodologies which you can let the dietitian know on about your eating habits, what are the different occasions or during the day when you are feeling hungry, what are your hunger pangs times, when you are hungry, how much are you eating, what is the type of food which you are eating, is it rich in fat, protein. So all this will help the dietitian to understand what is your basically type of eating, how what is the frequency, and then how much it is leading to the total intake of the calories. So these are different methodologies. These are quite simple ones. I would not go through each of them, but then this is just a summary of the records. Like this is the prospective way when you want to start a feeding or a diet plan. This is what the dietitian will tell you to after initiation of the plan in the next 1 week or so. So she knows that okay, after a diet plan is started, are you following it? And then before starting the diet plan, these are the different retrospective ways of understanding what is your feeding habits, which he or she can take it by calling you or taking your diet history, or there are some frequently asked questions on how is your uh, eating habits, and depending on the duration, that it would decide what methodology is being adopted to collect this information. And then of course there are mobile apps wherein you can just keep on typing what is the food you have intake, the time, and this is actually a very recent one. Most of my friends are using it. So this is again a way wherein you can measure your caloric intake. Now, having understood like what is the food which you are eating, you may also like to know like how much energy is being actually given by different ingredients of that food. So most of us know that carbohydrates will and proteins will give 4 kilocalories per gram, and fats will give 9 kilocalories per gram. So there are again different ways of evaluating how much is the caloric content of the food. No need to go in much details of this. Also, how basically the protein, fat, or carbohydrates are determined in the. So there are different experimental ways wherein you can use and evaluate how much is the content of each nutrient. So let's not delve more into it. So, okay, now having understood what is the food you are eating and what is the calorie in it, the dietitian may also like to know what is the type of energy getting expended from your body, right? So it is basically called as a total energy expenditure. And for a normal sedentary lifestyle, this is roughly 1500 to 300 kilocalories a day. So, and now most of this total energy expenditure is coming from, there are multiple components for TE. One of them is the basal energy expenditure, which is the basal energy which is required to carry out your, the basal metabolism and some, the vital functions also. And this accounts basically for 60% of your total energy. And the other 10 to 15% come from the thermic effect of the food, basically the food which we eat, the energy which gets liberated during its process of digestion, absorption, and storage. Then you also have a third component, which is uh, the excess which is coming out from the exercise, and it can be either divided into two. It can be a planned exercise, or it can be a non-planned exercise, or a minimal exercise of a sedentary type, wherein it includes simple activities which you are doing for day-to-day living. And then there is an adaptive thermogenesis, which is basically to maintain your core body temperature in a cold or hot environment. So why would any dietitian want to know about this? Is basically she would like to know about how is the basal metabolic rate of that person, so she understands when she is planning a diet how much calories should be allowed to to such a patient, or such a person who is on the diet plan. So there are again different ways of measuring the how much should be the how is the TE evaluated. So there is direct and indirect calorimetry, metabolic cart, room calorimeters. So basically these are all the methods in which for a particular population, maybe a child or a adult or a geriatric, these are these methodologies are applied to understand what is the difference in the basal metabolism or the energy spent by that age group of a person. So we have an understanding of how is the calorie requirement or the basal caloric requirement at these different age groups. So we will again not go much into this, and there are some equations based on these experiments. So if you want to know, if you want to meet the basal caloric requirements through our diet plan, these are a few of the ways, if which can be where the basal metabolic rate can be calculated and the calorie intake can be adjusted. Okay, now last piece is like the dietitian may also want to know how is your individual body and how it is how its body mass is actually made up of. Is it mainly the fat, or is it the protein, or is it the bone which is giving you the the mass or the body weight? So accordingly, if it's good to have more of proteins or bone weight coming in, but of course not the fat. And when you get obese or when the calories are higher, it's almost always the fat which is adding to your weight. So however, these are different methodologies wherein you can actually quantify of about like among your body weight, which portion is contributing to that weight. Is it the bone, or is it the fat, or is it the lean or muscle mass, and of course the visceral weight. So these are again the different methodologies to evaluate them. We will not go in deep, but maybe from exam point of view, you may just like to keep a note that one of the most gold standard is the hydro densiometry, and one which is widely used is the absorptiometry. So basically, these are few methodologies which may be asked to evaluate your BMR, or sorry, the composition of your body. And last piece is about how is your physical activity? Is it like um, are you a sedentary type or you are a worker? And once the diet plan and exercise plan is giving, you want to monitor it, like are you really burning certain calories in a day? So these are different methods wherein you can actually evaluate your physical activity. So these are the different ways wherein you are calculating the energy intake, your basal energy expense, and then this gives some background to your dietitian, like how to plan your activity and of course your diet. So we will come to yet another aspect of or a topic of discussion, and this is the biology of obesity. So as we discussed, we have evaluated through our ancestors, and then uh, the problem of obesity is something which is current, which has evolved over a period. Like earlier 10 years, a decade or 2 decades back, it may not had been that grave a problem, but today it is. So we are trying to understand right from the genetic level how it is originating, and what are those things which are making it even more rampant as we move on. So starting right from the genetic level, there is a hypothesis of thrifty gene, where we feel that earlier we were having a days of scarcity and days of abundance of food, and then there were these thrifty genes who helped us to during the scarcity period, and they made a very efficient way of storing the food which was consumed during the good days. However, as we moved on, today we don't have those periods of food scarcity, right? So these thrifty genes are, still continuing and making an influence wherein they give a feedback to keep storing the fat in our body for a future scarcity period, which actually never comes. So this theory says that this is the reason why we are, as we move on, we are getting obesity. So these set of genes are involved. However, there is totally contradicting theory which says that there is nothing like such, and actually there is a genetic drift or a random mutations which have happened over a period of time, and these are now actually responsible for us to make us more obese or eat more. So if we see overall genetic contribution, based on the experiments on mono and heterozygotic twins, what we understood is obesity is definitely heritable, and definitely there are set of genes which are involved, and if they are not functioning properly, they definitely will give rise to this problem of having a body metabolic pattern which is inducing you to store more calories. So there is this GWAS, which is genome-wide association study, which have identified around 50 loci in our DNA, which are associated with obesity if these are not functioning properly. And of course, there are some other epigenetic mechanisms over and above the genetic ones. So whenever there is a environmental or a psychological or other way, some of the chemicals are inducing DNA methylation of these genes, wherein you get into this problem of storing excess calories. Okay, so then there are some more hypotheses which are being put up, and these try to relate the obesity with different types of metabolic disorders, and we will talk more as we proceed. So this is where now we exactly start with what happens when actually excess of calories are consumed, and how exactly are the different organs getting affected because of the obesity, and how these are tried to cope up in the initial place, but then when these are overwhelmed, what are the different adverse effects which we face. So whenever there is a short-term increase in the caloric intake, we know that there will be an adjustment. It will be tried to stored in the fat depot or the adipose tissue, and the adjustments which happens at the tissue level is the hypertrophy and the hyperplasia of the tissues which are storing this fat in them. So this is totally adaptive, and once the caloric intake is reduced, this would go back to normal, the size of the cells. However, when this keeps on happening, when the calorie intake is continues to be higher, there are different organs now which comes to play, and then apart from the adipose tissue, which is actually supposed to keep the stores for a longer time, there are some other tissues which come into play. So of course the liver is one of the main, which tries to store this by converting all the excess calories, maybe it be from glucose or protein or lipids. It will convert it into triglycerides and store it, glycerol or triglycerides. Then the skeletal muscles, of course, they will also store a lot of glycogen and lipids. Pancreas is another organ which where we see the deposition of lipids. And what happens is when the skeletal muscles or pancreas or liver, these are overwhelmed with this, the insulin, which is actually supposed to prevent the lipolysis in the adipose tissue, it no longer can function, and that leads to increase in the levels of the non-esterified fatty acid. So what insulin would ideally do is it would get these tissues into converting this free fatty acids into a triglyceride or a lipid and store it. But because that is not happening, now you have an excess of non-esterified fatty acids. And what do they actually do is they would initiate cellular inflammation and damage, which is one of the as we see further, one of the pathogen etiology for adverse effects or the inflammation of higher calories or higher lipid storage. Then these are adipokines, which gives us give a pro-inflammatory cytokine, and induce what is called as a metabolic inflammation. We will talk about this more. Then there is a complete set of metabolic syndrome, wherein there is an insulin resistance, dyslipidemia. There is your lipid profile is totally out of shape. You also start getting into hypertension and cardiovascular dysfunctions, and these are type of a core systems which get into a metabolic syndrome. And in addition to it, there could be also an induction of type 2 diabetes or NAFLD, reproductive dysfunctions, and certain type of cancers which are associated with higher intake of calorie. We will talk about them in more. And lastly, of course, there is a correlation where we found that there is a reduction in the lifespan if there is a caloric higher calorie intake, and the reverse is true. If we do caloric restrictions, there is an extended life. So we in our olden days had this fasting inbuilt in our system. So that could be one of the reasons why our ancestors lived long, because they had a good periods of fasting. All right, so now what are the different types of adaptations which, before getting into the disease, or there are some tissue level adaptations which are happening, and which will try to prevent all the type of pathogenous adverse effects. But when these get overwhelmed, the disease sets in. So let us try and understand what are the adaptations which are happening in the liver and the adipose tissue. So first of all, we know that it will try to store glycogen and triglycerides in the liver, and also in the adipose tissue. Then about the transportation of fat, which is basically in the liver. So more we consume the fat, it will try to convert it into the chylomicrons and get into the circulation. So it is going away from the liver and try to deposit it more in the adipose tissues. And then what happens normally is when the chylomicrons are being circulated at the muscle level or at the fatty tissue, there are lipoprotein lipases which will hydrolyze these chylomicrons and get the triglycerides released, and then they will absorb this fatty acid and convert it into a triglyceride in their tissue. So basically this is how a fat will be mobilized from the liver and getting deposited into the adipose tissue. And then at adipose tissue, we also have this FATPs and the scavenger receptors, which will basically help to remove all the triglycerides from the circulation. Okay, then in the liver also, and also in the adipose tissue, there are these proteins which are called as PAT proteins. These are nothing but an extension of three different enzymes, basically perilipin, adipofillin, and TIP47. These are basically intracellular chemicals, and these play a role in how the cell wants to convert the extra triglycerides into a fat and get deposit within the cell. So if you see a fatty liver, most of the hepatocytes, they have a droplet of fat inside it. So when to store this as a droplet, when to mobilize it, when to initiate the lipolysis, all this is happening through these chemicals within the cytocells. So they play an important role in regulating the droplet stability and the triglyceride turnover. We know that temporarily liver stores this lipid droplets. However, when it gets too much, the size of the droplet increases, and then the nuclei are pushed towards, and then typically that is when we start calling it as a NAFLD. Also at the adipose tissue level, we saw that there is hyperplasia and hypertrophy, and then large storage droplets are found within the cells, which indicates that they are trying to accommodate and store the excess fat which we are consuming. This is something very interesting, where how excess calories are also, affecting the gut microflora. So what happens is, when we are having food which is high in calories and fat, there is an alteration in the group of microbes or the microbiota. So there is a reduction of type of bacteria called as Bacteroidetes, but there is increase in the type of bacteria that is called as Firmicutes. What happens because of this is that there is a change in the way our food is getting fermented by these bacteria. So it is hypothesized and postulated that when an alteration happens in the microbial biota, there is a different type of fermentation, and then there are different chemicals which are getting released in an altered way. So some of the satiety signals which are sent, like YY propeptide or ghrelin, these are altered. There is also alteration in the insulin action via the GLP-1, and then there is an increased fatty acids, small chain fatty acids. Usually fatty acids, they are used for the lipid synthesis, but due to alteration in the way these are getting digested, there is a different set of signaling which happens, and this alters your a tissue level feedback mechanism from your tissues to the brain, and it affects basically your diet habit, and also the fatty acids which are getting absorbed or stored or giving you the energy. So this is something which is interesting, but you may like to know it just for the sake of academic. Then whenever we eat carbohydrates, so excess sugars, basically they are stored in the form of a glycogen and this is up to 7% of the liver weight. That is when that is some of the limit which it can be stored up to. And then all this even more as it keeps coming, the liver will try to convert it into fatty acids and triglycerides, which is nothing but the lipogenesis. So when all this is happening, this is happening because at the genetic level there is increase in some of the key transcription factors like the SREPP1 or CHREPP, which will help to make all these changes to accommodate the excess calories which we are having or consuming. And then there is some limit also for the adipocytes for expansion. So what is known as for especially the subcutaneous fat, it can expand more safely. There is, it is a safer fat type where the more we eat, it can, if your body is trying to store it in the subcutaneous fat, it is actually saving us from all the adverse effect. However, if it is the visceral fat which is going to expand, then there is some limitation to it. And after once it is expanded to its full capacity, there will be set of all the pathogenesis which gets triggered and which will be causing all the adverse effects. So, all right. So then once the capacity of our hepatocytes is and our adipocyte cells is overwhelmed, when they cannot absorb more, or then when there is a restriction of hypertrophy or hyperplasia, there are some other cellular events which initiate, which basically type of excess of accumulation of calcium and cholesterol within the cells, and which leads to the break of these cells and release of DAMPs, which are damage associated molecular proteins. There are some other set of cellular chemicals as well, which once these trigger basically more inflammation, they give rise to more inflammatory type of a cytokine reaction and activation, which eventually leads to inflammation and macrophage activation. In addition, there is also remodeling of the extracellular matrix. In one of the reason is to attempt accommodating more of the lipid storage capacity, but at the same time, when this gets overwhelmed, it tries to replace the damaged part by a fiber or fibrotic tissue, and then this is where once the fibrosis sets in, may it be liver or adipose tissue, it type of makes the organ to more towards the dysfunctional. uh, uh, I mean, the proper functions could not be carried out, and it results into slowly the failure of that particular organ, especially the liver. And then we understood that there are some genetic models. If some mice are knocked out for some of the genes, which actually uh, you know, uh, I mean, if these mice do not have this genes, they would not have the extracellular matrix remodeled, and that will actually save them from the harmful effects of remodeling. So in a way, if our body is not trying to accommodate or repair some of the things by fibrosis or extracellular matrix remodeling, it is a better way of handling the fat rather than using this ECM remodeling method. So this is in short explained in this diagram. I'll just quickly go through it. All right, so this is where we are at a normal person, and when the excess calories are consumed, there are two ways. One, there is increase in the lipid storage, and this is the obese fat. This usually happens in the subcutaneous tissue, where it can go on accumulating more than what it can in the visceral fat. However, what happens in the visceral fat is this will give rise to all other pathologies which we just described, and then there will be a setting up of inflammation and eventually the metabolic syndrome. And as we just discussed here, these mice which were deficient with SPARK-A4 collagen genes, when they were knocked off, these could not undertake this pyrotoxis, and because of which their adipose tissue could accommodate more fat, but without any increase in the metabolic syndrome or adverse effects of the inflammatory adverse effects. No doubt there was an increase in the weight gain, but there was no harmful effect which was more as predominant, which happens with the metabolic syndrome or the pyrotoxis or the inflammatory way. Okay, so which are all the other adverse effects in addition to this is, so I'll increase the size again. So the other way the body tries to deal is, we just spoke, this is the ectopic fat deposition, which happens in the liver, skeletal muscles, pancreas, small intestine, and also in the uterus. And in fact, this is the reason why some of the malfunctions kick in, and then we suffer. The functions of these organs also suffer. So when it happens in the liver, this is called as a non-alcoholic fatty liver disease, wherein your hepatic weight is more than 5% of your hepatic weight is contributed because of the storage of the lipid. And then you can reconfirm this by taking a biopsy, or in the killed animals, by undertaking this type of a special staining, which reconfirms that this is a triglyceride accumulation. The reasons for that we know is increased fatty acid supply, increased lipogenesis because of the increased calorie intake, reduced fatty acid oxidation, and reduced VLDL synthesis are the additional factors wherein the liver cannot root out your lipids or absorb lipids through chylomicrons or VLDL. And then there is a reduced fatty acid oxidation. One of the effect is because of the insulin resistance, which also, where insulin is important hormone to not only absorb all these excess calories in the muscles, but also to activate them in the metabolic cycles. So that is also not happening, which all eventually leads to hepatic accumulation. So in the liver, this is what happens. we call it as the non-alcoholic fatty liver disease. In the skeletal muscle, again, it's a similar way, but it is called as the intramyocellular lipid. And again, this is nothing but triglyceride within the muscle cells. And these are the different absorption, the molecules which are interacting and, storing or helping to snatch out the lipid from the circulation and store it. One important thing again in the liver is if there is, in the absence of again insulin or insulin resistance, there is no particular sufficient intake in the muscles, and then whatever is stored in the muscles is broken down. There is lipolysis and there is increased formation of free fatty acids. Then these are some other pathways and important hormones at the tissue level, which which are involved in either lipid lipolysis or absorption of the lipid from the circulation. The third important thing which happens with the caloric toxic effect of the calorie is the metabolic syndrome, and this is a syndrome wherein which has some core components and some additional components. So core component is basically the waist circumference, and there is a increased visceral fat and abdominal fat, which is also giving rise to an insulin resistance. We call that the body is in insulin resistance if the fasting glucose is more than 100 milligram per deciliter, and also there is an increase in the insulin level, the fasting insulin level. Dyslipidemia, where your HDL is lower than 40 milligram per deciliter in men and 50 in women, and there is of course a triglyceride level which is which is higher than 150 milligram, and this also sets into an hypertension where your blood pressure is higher than 130 systolic and 85 diastolic millimeter of mercury. So when you have these symptoms, you call it as a metabolic syndrome, and eventually there is an increasing trend. We see these numbers, and then there are some set of population which are more predisposed to it, especially the Mexican Americans who are having the higher incidence. So what is the pathology behind this? We just discussed most of it. So I may not go in again through all these details, but yeah, I mean, this all come into play, and there is all these adverse effects happen which give rise to this syndrome. So this is explained diagrammatically over here. And then how do we address this metabolic syndrome? So this is having a multifactorial origin. So you may have to treat at different tissues or a different complaint, different factors of it. So basically you start with, of course, this is the lifestyle management with diet and exercise, and then there is also bariatric surgery which can be indicated if your BMI is more than 40 or there are some other morbid conditions, then this is undertaken. There is, of course, a pharmaceutical drugs which we are rampantly using. Most of them is to treat the insulin resistance or hyperglycemia, metformin and the thiazolidinones like the PO and rosiglitazone is being used. Then for addressing the dyslipidemia, we have the statins and multiple combinations with them. And of course, we also try to give a better form of the fatty acid, which are the omega-3 fatty acids, which are known or proven to reduce your triglycerides by 20 to 40%. To treat the cardiovascular component, you have the beta blockers to reduce the blood pressure. You have the diuretics and the ACE inhibitors, which can help to relieve the symptoms. And of course, as we discussed, we have a newer type of therapy, which is the gut microbiota or the probiotic, which will again alter the milieu of the intestine. It will modify the local feedback mechanism and eventually help to have a better profile of your lipid and calorie balance. So this is the summary in short of how the metabolic syndrome is addressed. We discussed about the the NAFLD, and what we also need to know is if this calorie intake continues, then it would eventually progress into something which is called as a NASH or non-alcoholic steatohepatitis, where continued accumulation of fat will eventually lead to more inflammation, cell death, and fibrosis, which is then called as a NASH, and then the cirrhosis sets in, and if it is not addressed at that point of time, it can continue to develop into a hepatocellular carcinoma. So again, this development to NASH and HCC is again increasing, uh, and then there are multiple ways of diagnosing it and treating it, which more or less the strategy remains the same. But as these are different factors which are and the molecular mechanisms which convert this energy storage into more problematic NASH or hepatocellular carcinoma. So again, there are some approaches to this. More or less, principally they remain the same, just that the intensity or the severity is higher to address NASH and other problems. So what is the impact which excess calorie or obesity can have on the drug pharmaceutics? So basically, because of the increased lipid or the adipose tissue, if the drug is lipophilic, it will get distributed more in this tissue. It will get stored over there. So for the lipophilic drugs, you will have increase in the volume of distribution. It can be as high as 400, increased by 400 liters, but it may not matter much for a hydrophilic drug. Then is the clearance. So it can affect the clearance of some of the drugs, especially if there is obesity and NAFLD. It can affect the functioning of some of the CYP enzymes and the sulfotransferases and other uptake inhibitors and transporters, which can eventually have an impact on the plasma levels. And the half-life also, because of the increased distribution, there can be an increased half-life and other impact on the overall pharmacokinetics of it. So when a patient or obese patient or a patient with higher calorie positivity is given different types of oral contraceptives or other drugs, the doctors may like to keep in mind that some of the part or the initial dose may be given as a loaded dose, so it doesn't lead to reduced plasma level and loss of efficacy. So other impact of higher calorie intake is on the endocrine dysfunctions. There are multiple organs which can get affected and different stages of physiology. So during the pregnancy, it can adversely affect the fetal fetal risk, and also affect the lactation, and if the mammary glands are impaired because of higher fat accumulation. There is increased insulin resistance and hyperinsulinemia, which we just discussed. And one impact is also on the androgens, how the way they are handled and produced basically. So most important finding these days is in the girls, where there is increased adrenal and androgen synthesis, and then this is leading to early puberty, PCOS like syndromes, anovulatory cycles, basically subfertility and infertility. Whereas in boys, it is also leading to hypogonadotropic hypogonadism. Thyroid also more succumb to hypothyroidism is one of the common output of metabolic syndrome. So these are the other endocrine organs and functions which get affected because of high calorie intake. These are some of the cancers types and the tissues which can get affected and get into a cancerous state, and these are related to or associated to obesity. And these are the different possible hypotheses that how different agents would be having a role in increasing the cancer risk. So benefits of caloric restriction we just spoke, and this is not only found in humans, but it is also seen in all
almost all other species which we can think of, right from yeast to rhesus monkeys and humans. And then this was an actual study which was conducted called as the calorie study, where it quantified and really proved that how advantageous is the calorie restriction can lead. So based on these findings, there are some compounds which are being trying to synthesized and see if these can be used to reduce the calorie intake. One of the compound is resveratrol, which is basically coming from a grape of polyphenol, which activates the set of genes called as the SIR2, and it is being currently explored to see if this also mimics or creates a situation of fasting, and if that increases the lifespan. So is the drug rapamycin. This is known to inhibit or the inhibitors of TOR, which is target of rapamycin. This is a specular pathway, a pathway which is actually integrating the caloric intake, the muscle mass, and then how the nervous system is addressing it. And if this is inhibited, if this target of rapamycin pathway is inhibited, then there is a way this mimics the basically a fasting physiology, and then it can help to reduce your calories and increase your lifespan. So treatment of obesity, it's more or less in the similar principles, where mainly you want to have your expenditure of energy more and more than the intake of the energy. So you have different goals, not only dietary goals, but also physical exercise goals. And then these are different ways how the caloric intake and expenditure of energy is calculated, which that, as we discussed, dietitian would like to know based on the physiology of a particular patient, case by case, to devise the diet plan and the exercise plan. Okay, and these are few things which are considered during devising a plan. Okay, and now we move to few of the adverse effects when we are on actually dieting. So when we are on dieting, we should make sure that we are making us deficit only for calories. All other nutrients, they should not get deficit, especially the minerals or the important vitamins and the proteins. So so one of the adverse effect of dieting, if it is not properly devised, then of course is the nutritional imbalance, where you may fall short of other important vitamins and minerals. Then there could be because of the choice of food which you are having or a diet which you are consuming, that can adversely or impact your metabolism pattern. So say for example, if you are in a diet plan and if you are losing your adipose tissue, which may have stored some drug or which may be storing some drug which you are concomitantly taking, then the plasma levels of that drug may be higher, because now it is no longer getting distributed in the adipose tissue and it is there in the circulation. So these effects can be noted. Also, there could be some inhibition of the CYP enzymes or the induction of them, depending on what ingredient you are using. And the third side effect is the yo-yo effect, where you see a pattern that when you start a diet, you have a weight loss, but then somehow you are not able to continue with it, and then there is a rebound of it where you are actually gaining more than what you have lost. And if these keeps on continuing, you may get into cycles where eventually, instead of having an advantage, you may have increased fat in your body. So some of the drugs are being tried for the therapy of weight loss. This is basically a sympathomimetic drug, which was diethylpropione, which was tried as a very advanced stages of this. But then what we understood is it had some mechanism where it controlled the hypothalamus and the hunger signals, but because of the short and long-term side effects, it was not considered to be a good sustainable remedy. And lastly, we have the surgical intervention, sorry, where we can have either a bariatric surgery, where we can reduce the stomach capacity in terms of volume, and it helps to have a quicker satiety, so reduced feed intake. And these are the different ways wherein you can reduce your stomach volume, which are indicated for different types of BMIs, and with and without the comorbid situations. Of course, these come with some drawbacks, and then these are some complications of this surgery, like gallstones or malabsorption of important components. Then you may have to undergo a dietary restriction, and lifelong supplementation is required because of the changes in the anatomy you're doing to the stomach. And lastly is the liposuction, which is not as severe as the bariatric surgeries, but then these two are helpful in addressing the local removal of the localized fat depots. So basically, these are removing your fat tissues. So this is the important piece wherein how obesity and increased calories is actually affecting the health system and the insurance system. So most of us know that when we are wanting to buy a health insurance or life insurance, we are asked about our BMI, and we are asked to undertake some of the tests. So basically, uh, what the health insurance companies knows that when you are obese, or if your body mass index is higher, you are succumb to more type of an adverse effects, and then they try to address it by either increasing your premiums, or uh, you know reducing the advantages which you may get after the insurance is over. So the point is, what impact does the caloric intake or obesity have is this basically on your insurance, the way you want to buy it, and how it can adversely affect on either in your premium or the coverage which you are getting. And this is very important in US system, where most of the monetary load of treatments is being on the federal government, and federal government would like to have lesser number of patients who are adverse or morbid, or not have such type of a caloric problems, because uh, the burden on them to treat all these excess morbidities, sorry, comorbid conditions, is even higher than for a lean. And apart from that, there are some initiatives where the agencies or different regulatory agencies have tried to understand, not only at the level of the individual, but at a level of a community or a state or a national level, that why there is a rise in the obesity incidence. So what they understood is, before 1970s, the body mass indexes were much better than they are today, and one of the reasons were, uh, there was a higher physical exercise classes during the schools or colleges. The eating habits were good, where most of the consumption was a home cooked food with fresh ingredients, and the commutation was happening through biking or walking, which involved the physical exercise, and then there were no video games being played, or less sedentary lifestyle. But that was not so, and it get reflected after 1990s or 2000s, where we see that the BMIs were much higher than what they were earlier. So having understood that this type of a lifestyle, there is initiative to have more community gardens, then the revival of the physical education in the school, then removing unhealthy vending machines from the organizations or schools. So these are the some of the steps which the government is trying to encourage that local schools or organizations take up. And then finally is the regulatory framework. So FDA basically has an oversight of how to label not only the domestic food but also the imported foods. It is making sure that these laws which are there are enacted and they are complied to, which basically address how do we put the labels, what should be there and what should not be there. Then there are some labeling requirements which are you know for the different types of the foods, which may or may not be required. So this is definitely required for this type of a food where you clearly give out your label requirement in terms of what it contains, what are its calories, what are the different nutrients which its composition is, all these things which you have to give on the label. But you may or may not give for other type of food like the raw produce or fish. And then these are some dietary supplements and functional nutraceuticals, which are again regulated by FDC and Act. But then they also have some different rules which are to be looked for. So basically, the enforcement is by the FDA, which monitors what are the when you're talking about the claims. The FDA will ensure that okay, whatever you are putting a claim that this is helping in reducing the inflammation or this is helping in reducing your fatigue, the FDA will try to check back and really see if that claim is worth putting it on the label. And if there is any suspicious or a doubtful or a misleading claim, then this will be challenged. And if this is challenged, the company has to address the FDA warnings within 15 days of the receipt of the challenge. Then there is also an impact on for the chains of hotels and vending machines, that if which is under the Act of the Patient Protection and Affordable Care Act. So you have to give the number of calories in your menu item, and menus must indicate how much percentage of your total daily intake will be given if you consume one particular type of meal. So this is particularly required to be followed when your chain of hotels or vending machine is having more than 20 operators, and then you have to follow this procedures of letting the people know what the calories are and how much do they make up for the total daily intake. So basically why are all these efforts made? So that the person who is consuming, he knows or he is aware that okay, if he is on the weight reduction plan, he knows how much he is consuming. He can have an informed decision or a choice of what to eat and what not to eat. And you may like to know, or it will be interesting to know that in New York it was the first time where the restaurants were required to add on a column, not only the menu, the price, but also how much is the calorie and the nutrient information. And California was the first state where it banned the use of trans fats based on the adverse effects it's had on the cardiovascular system. So these are a few of the things which got impacted and got into regulations, and which the FDA is now following. These are a few other cases where people who are obese have complained about discomfort in the planes, or also being teased by the other lean passengers, and then how they put up a case, or how the workplace at some workplaces or schools, some of the students or members, because of their obesity, they were teased. So these are some other implications which is not much important. But one thing which is coming out is people are feeling that if regulations are going into so much deep, are they going to decide what we should eat and what we should not eat? So this is something which is coming up out as a challenge, where at one point the regulation is trying to come up and help to better the health by reducing or having a check on the calories, but at the same time it is not liked by everyone, every individual, because he feels that his privacy is intervened, and the agency should not decide what he wants to eat or not want to eat. So that's all for this. I think it's quite some time we have discussing. So all the best for your exam, and If there are any questions, I can take up or address it by email in some more time.